Hi, I'm Dr. Simon Fry, a consultant in clinical neurophysiology. Welcome back to the channel, and in this video I'm going to be talking about juvenile absence epilepsy as a follow-on to my previous video on childhood absence epilepsy. Before I continue, please do show your support for the channel by hitting that subscribe button down below. Juvenile absence epilepsy is different to childhood absence epilepsy in a number of ways. First of all, in terms of how common it is. It makes up about 2% of epilepsies, and its prevalence, the amount of it that's out there in the population, is estimated to be about 1 in 10,000. So for the UK population of 60 to 70 million, we're talking about 6,000 or 7,000 people who are affected with this in this country. Now, previously, before developing these seizures, they will have had normal development, and a small proportion will have had a history of febrile seizures. You can see a separate video to that by clicking on the icard above. And then maybe a family history of an epilepsy. It doesn't have to be the same as juvenile absence epilepsy, but it's an epilepsy as well. Some may have even been diagnosed previously in the earlier years with childhood absence epilepsy and are now being re-diagnosed or reclassified into juvenile absence epilepsy, and we'll talk more about that a little bit later on. The peak ages are about 12 or 13, but the age range can span a bracket of 9 to 16. And so there's an overlap in age with childhood absence epilepsy, which can make the diagnosis tricky. Interestingly as well, the ratio of girls to boys, females to males who develop this is about the same, and that's different to childhood absence epilepsy and also to juvenile myoclonic epilepsy, where there is actually a female preponderance. And so in terms of the genetics, this is already telling us that there is something a little bit different going on over here. In terms of its expression, how it manifests itself, the hallmark again is with an absence, where people stop doing what they're doing, they're zoned out. But actually, in terms of its disruptability, really, if that's the right word, to consciousness, it's not quite as disruptive. Neither is it as sudden as that which occurs in childhood absence epilepsy, and in fact maybe of longer durations too whilst they're happening. So it can actually be easier to confuse with daydreaming episodes, and in fact, whilst people are having these absences, they may actually be able to operate at a low level whilst it's going on, and so it's really not quite as disruptive, and because of that. So apart from the absences, people can also have myoclonic jerks as well. About 20% have some myoclonic jerks, maybe some clonic movements, some tonic movements. That means when people get stiff and rigid. People may become atonic when they lose the stiffness within their muscles, and they may have some automatisms where they sort of go onto autopilot doing some simple things. About 80 to 95% even of those who have juvenile absence epilepsies may have a generalized tonic-clonic seizure as part of this. In fact, it can even present with this in rare occasions prior to the absences happening. So in contrast to childhood absence epilepsy, where this is quite rare, this is actually quite common for people to have these generalized tonic-clonic seizures. Tonic seizures, the tonic component is where people become very stiff and very rigid, and then the clonic ones are when they start to having rhythmic movements like so. Now, very importantly, the seizure frequency is much less than in childhood absence epilepsy. They may be having less than one a day, and in the old terminology of all of this, it used to be called spaniolepsy because it was much less frequent than those in childhood absence epilepsy, which was known as pycnolepsy, where they're having lots and lots and lots of these every single day. Now, in terms of could it be something else, we've talked about childhood absence epilepsy, and really there is an overlap in age, particularly at the younger age of the juvenile absence and the older part of the childhood absence brackets. And if you look at the International League Against Epilepsy definitions, really it's the seizure frequency which is absolutely key in differentiating the two in this kind of border zone land of about the ages of 8 to 12. However, the challenge really is recognizing absences, because even in childhood absence epilepsy, it's very often that the seizures are not necessarily recognised by the parents or carers, and often may just be recognised by teachers. So non-recognition of absences is a real issue, and that's really one of the beauties of the EEG, which we'll talk about soon, is that it's much better to capture that kind of activity. The other thing which it can be confused for is juvenile myoclonic epilepsy. About 20% of juvenile absence epilepsies will progress into that phenotype, into that descriptor of juvenile myoclonic epilepsy. We will talk about that hopefully in the next video. There are other things it can be confused with, but they're much rarer, but these are the main ones. In terms of the tests, well, we have the clinical bedside evaluation from the person who is experienced at dealing with this, and they'll do a history examination. They might do some specialised things in the clinic like hyperventilation, but really the key here is actually the EEG, which we will talk about shortly. Imaging is not usually important to making the diagnosis. If it is done at the initial stages, it will usually be normal, and we'll talk about more imaging aspects towards the end of this talk soon. So in terms of the EEG, the background activities should usually be fairly unremarkable. Should be no focal slowing or generalized slowing. This is a little bit in contrast to the childhood absence epilepsy. One can get these posterior slow waves, which we've talked about. However, within the background, it's often not fully normal because they're often fragmented spikes and polyspikes embedded within it. There can also be bursts of interictal activity or generalized spike waves or polyspike waves, usually between 3 and 6 hertz, usually on the faster side around the 4 hertz plus side of it. If it's less than 2.5, then it's usually something else. Sleep deprivation enhance the discharges and will also enhance the fragmented discharges within. Hyperventilation is once again a trigger and an enhancer of these activities. And really interestingly, intermittent photic stimulation, when you have a strobing light, a minority will be light sensitive. And that's in real contrast to those who have juvenile myoclonic epilepsy. And so it might actually be a clue that a JAE may actually be a JME. But there's quite a wide variety of data within the literature about the degree of light sensitivity, but overall most will accept that light sensitivity can occur, but it's rarer. In terms of when people are actually having seizures, the hallmarks of that will be a regular generalized spike or polyspike wave discharges, again between 3 and 6 hertz, just gone for longer. And if a generalized tonic-clonic seizure is being captured, usually one finds generalized polyspike waves occurring first, and then that will be followed by spike slow waves, and then after that phase is finished, then there'll be irregular post-ictal slowing. So those are the phases in the tonic phase: the fast rhythmic spikes, the clonic phase, the spike slow wave spikes, and then this irregular post-ictal slowing. In terms of those who may be classified originally as a juvenile absence epilepsy when they were originally diagnosed with a childhood absence epilepsy, I've discussed this in a little bit more detail in the previous one of childhood absence epilepsy, but just to reiterate the point that in terms of how we classify these conditions, it really does make a huge difference. The more tightly we define the classification, the more likely we are to get the right diagnosis, and getting the right diagnosis is absolutely critical in terms of giving the right amount of treatment and the right advice in terms of the possibilities and probabilities of going into remission from these type of epilepsies. And so this particular study by Giolotto and colleagues, when they applied a tighter definition from Panaritopoulos, basically the number of childhood absence epilepsies that they had reduced, and the number of juvenile absence epilepsies increased. In terms of the treatment, first-line medications for anti-epileptics would be sodium valproate or Epilim and lamotrigine. the choice will depend in part on side effects and tolerability, but also in terms of whether we're talking about a lady of childbearing age. We try and avoid sodium valproate for a variety of reasons in that category. And so lamotrigine might be the preferred option in that scenario, but there'll always be a discussion with the patient about the benefits and the risks and so on. In terms of ethosuximide, it's not as effective in juvenile absence epilepsy as it is in childhood absence epilepsy, particularly when there are generalized tonic-clonic seizures involved. And as I've said, that's usually a feature in about 80 to 95% of people who have it. So yes, it is an option, but usually reserved for those who only have the absence aspects of the JAE. Quite often there will have to be a combination of various anti-epileptic medications, and other anti-epileptic medications may have to be tried. Overall, it's said that response rates to treatment are about 75% or so. There is certainly a role for the ketogenic diet, and whilst treatment can be very effective, it can also be lifelong, which now brings me on to the subject of remission. Now, in childhood absence epilepsy, as a rule, those who have it grow out of it. Unfortunately, in juvenile absence epilepsy, whilst it is said, and you'll see this in a variety of epilepsy websites, that maybe about 75% of people can eventually come off the medications. If you look at many different case series, unfortunately it doesn't bear out that way. And so there'll have to be discussions between the caregiver and the patients, those who have it, whether it is worth having a go coming off from these anti-epileptic medications, and that's a discussion sort of beyond what we can talk over here, whether or not it might be appropriate to do follow-up EEGs to see whether or not there is scope to safely reduce the anti-epileptic medications, and so on. However, I should say that if people have generalized tonic-clonic seizures as part of their juvenile absence epilepsy, then it's actually associated with reduced remission rates. There are other developmental issues that also need addressing. We talked about in childhood absence epilepsy, given the massive frequency of the discharges and the disruption that they can cause to the neuronal activities, there can be effects on people's long-term attention, behavior, cognition, emotions, and the same actually holds true with juvenile absence epilepsy. It can also affect all of those, but not quite because of the disruption to the neuronal mechanisms per se, but there can actually be degradation with time in the various parts of the brain. I've popped a reference to one such study over there. In the parts of the brain that look after attention, memory, and so on, they can actually become impaired with increasing time. So it's far more complex than the simplistic mechanism that we would propose in childhood absence epilepsy. In terms of the channels and the genes involved in hyperexcitability or reduced inhibition or abnormal connectivity, it's much less clear than the situation is in childhood absence epilepsy. There are lots of different types of channels, lots of different types of genes that have all been implicated in one way or another, but they tend to be far more complex and far more subtle and far less reproducible when you start looking across larger populations. And so there's a lot that we have yet to learn in terms of the causation of this. It's not one gene, it's likely to be polygenes, many genes acting together, possibly some environmental triggers or so on, but we don't really have a clear answers to why this happens at the moment. And so this really brings me to the next item of discussion, which is there an overlap, is there a continuum of childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy? And if you look in the older parts of the literature, there used to be some various diagrams of these conditions overlapping over each other, and I would put it to you that our understanding now has moved on from that, and we have a much greater perception of how these are different conditions, albeit with similar manifestations. And that's where these crossovers and continuums questions really arise, but actually they are almost certainly different conditions. And as we've seen with childhood absence epilepsy, once one understands the genes involved, one can hopefully better try and predict which medications, which treatments might be the best way forward. So we still have much to learn in this regard. I hope that you found this video informative. If you have, please do support the channel by hitting that subscribe button down below. Your questions and comments are always welcome. If it's anything specific to yourself or to your child, I won't be able to answer that, but if it's a question in general, then I certainly will try. Wishing you all the very best and hope to see you in the next video.